All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, the discussion today is about a Swedish study that has shown that after mild or asymptomatic SARS-CoV-2 infection, there has been reactivation of latent viruses, for example, herpes or EBV. However, in the patients who are already patients of MECFS or myeloencephalitis chronic fatigue syndrome, this reactivation of the viruses was more aggressive, which caused the immune system to respond more aggressively as well. But what is unique about this study? There are two things that are unique. Number one, this is the first study that shows the reactivation in asymptomatic or mild unvaccinated individuals. And number two, this is the first study that shows that even when plasma of the patient does not show antibodies against latent viruses like EBV, the saliva shows antibodies. So it becomes very important for doctors, for providers, to make sure that within 3 to 6 months of a past COVID infection, they test their patients, especially those who may have long COVID like symptoms, for their saliva and the latent virus antibodies in the saliva. Or imagine if they cannot do those tests, then at least assume that some of the patients may have developed MECFS or had aggravated MECFS because of viral reactivation because of SARS-CoV-2. So that is the study. This is the summary of it. So if you're a doctor, if you're a provider, NP, PA, make sure that you keep an eye on your post-COVID patients and have these tests done or have a management approach ready for such patients. Let's look at the study. So first of all, this is drbeen.com. For you, for this Thanksgiving, happy Thanksgiving, there is a link in the description of this video with a one-time fee of $67 to get you access to 900 great, I think these are great, I'm biased, these are mine, and another 17 doctors. These are great medical lectures. So get access to them. This is not a monthly recurring fee. This is a one-time fee only. Okay, so with this, here is the study. Saliva antibody fingerprint of reactivated latent viruses. So here, when they talk about reactivated latent viruses, they're talking about EBV and herpes and uh, endogenous retroviruses. After mild, asymptomatic COVID-19 is unique in patients with myalgic-encephalomyelitis, chronic fatigue syndrome. The point they're making here is that patients who are, or individuals who do not have MECFS but get COVID, they also get these viruses and activation of these. However, the MECFS patients get a more aggressive reactivation. And then there are lots of interesting points in here. I will go over majority of those and then we'll discuss further. There are some very interesting diagrams here as well. We'll see if we can go over these two. And then there is some more in the link, in the description of this video. There are some links for some more aspects as well. So with this, before I start with this study, I want to very quickly, actually, I am right now texting with a patient, not my patient, I don't practice here in the US, but a patient of severe vaccine injury. I think in my experience, I haven't seen anyone more severely injured. I've seen more equally injured. And this patient has just told me. So she and I was discussing the value of sauna for mitochondrial reactivation and reduction of inflammation and survival of cells and so on. So today she decided to go to a sauna therapy, and her message was like magic for me. She said that for the first time in months and months, she felt her brain was able to work properly, and she felt less gripped by a disease, and she felt more coherent with her brain's activity and with her word finding and those things. And this was just one therapy with sauna for 20 minutes. I have said it previously as well. Both the near infrared and sauna are very helpful. However, they both should be separately used, because near infrared for mitochondrial rehabilitation is the dosage is only for 10 minutes. Above 10 minutes, it loses its efficacy. And sauna, which is a thermal heat, is best at 20 minutes. So don't use them together, because either one or the other's effect will be lost. So 2 doses in a day, near infrared for 10 minutes and sauna for 20 minutes. And I think you would see lots of benefit. Okay, so now we start. So happy Thanksgiving in advance. I hope and I pray that you all stay safe, happy, and healthy. Thank you very much to everyone for being here with me for about 3 years now. In a few months, will be 3 years. And for your support, for your love, for your care, for your participation of to keep yourself safe and keep the people around you safe. So thank you very much. This is the cartoon with this video, because it is all about saliva, this talk, that is why. And these are gifts for humanity. They're continuing. And here is the study. So even asymptomatic patients. So why do we talk about even asymptomatic or mild? The reason for this is there have been tons of studies that show reactivation of the latent viruses in severe COVID. Hospitalized patients or ICU bound patients have shown reactivation again and again. And normally that is looked at as because the patient's immune system isn't functioning correctly, it is suppressed, it is busy with the COVID, that allows the other viruses to become, to bounce up. And I hope my audio is working. So Casey said, can someone with dysautonomia safely do sauna? I think with a supervisor, one should try. And if it is something that due to sweating or other reasons, it becomes a problem, just stop. But for the first time, one can do that with the doctor's permission and the supervision. John says we can hear Luffy. Yes. So Luffy today somehow is not outside. He is just lurking around inside and doing his things, singing the songs of his people to us and to all of you as well. I think he's saying thank you for your support and love as well, and to listen to his songs for 3 years. Okay, so severe and ICU bound patients, we know have reactivation, but asymptomatic or mildly symptomatic and unvaccinated patients, we did not know. And one of the reasons researchers said we did not know was that most of the time patients are tested with their plasma, their blood. And many of these antibodies that they are looking at here were significantly increased in saliva but not in plasma. And they have a few conjectures for why. But this is the importance of this study. So, even asymptomatic COVID patients can cause or can have reactivation of latent viruses, especially EBV, HHV, human herpesvirus, and HERVK. More intense in patients of ME/CFS. And the patients that participated in this study were all unvaccinated. They all enrolled in the second half of 2020. So what did they see? They found HHV6, EBV, and HERVK more prominently activated. So what is the takeaway of this study? The takeaway, I said that before as well, I'm going to repeat it. The takeaway is almost every person who got COVID had a chance of reactivation of the viruses, that is healthy or with ME/CFS or not. But ME/CFS patients had the more brutal activation, and their body responded more aggressively as well, and that caused those symptoms. So these authors even thought that maybe part of the long COVID in some patients is because of the viral reactivation. This also reminds me that if you watch my videos with Dr. Keith Berkowitz, sometimes he would say, "Hey, have you been observing EBV? I'm seeing a lot of EBV nowadays." And so I think I discussed the EBV reactivation about 1.5 years ago in from one of the studies here. So mild or asymptomatic infection, 3 months to 6 months, within 3 months to 6 months, both cohorts of this study, that is healthy individuals who got COVID versus ME/CFS who got COVID, both cohorts, some of the patients in there developed the reactivation, however, more intensely in ME/CFS. Also, this is very important. EBV encoded nuclear antigen 1 or EBV reactivation in some patients were only present in the patients of ME/CFS. An author said that they are not sure that this was because the EBV was present that caused the ME/CFS, or it was this ME/CFS present and then SARS-CoV-2 which caused the EBV. But patients of SARS-CoV-2 who had ME/CFS, they had developed EBV reactivation, which healthy patients, healthy meaning no ME/CFS patients who were COVID positive, did not develop EBV. So EBV is a more typical reactivation even in asymptomatic or mildly symptomatic patients, patients who were already ME/CFS. So what is their conclusion? They say, our results denote an altered and chronically aroused antiviral profile against latent viruses in ME/CFS. SARS-CoV-2 infection, even in its mild asymptomatic form, is a potent trigger for reactivation of latent herpesviruses and endogenous retroviruses as detected by antibody fingerprint locally in the oral mucosa. So if you are a provider, if you just take one thing away from here, that is test the patient's saliva, or if you have tested their blood samples and they are negative for the reactivations, but the patient is showing symptoms, then assume at least that they may have reactivation. And then the researchers say this has not been shown before because the antibody elevation is not detected systemically in the circulation or plasma. I could actually just stop here. Now, there are some interesting parts of this study that I think we should look into. We are kind of done. Both biological and clinical markers point towards a state of acquired immunosuppression in severe SARS-CoV-2 infection. So before you take away the term acquired immunosuppression and become worried, they're talking about severe SARS-CoV-2, and we know in severe SARS-CoV-2 cases, immunosuppression occurs. So they say that may explain the non-supervised prolonged latent viral reactivation in these patients. However, most infected persons show mild or no symptoms and report on long COVID cases do not necessarily correlate with the severe infections. So what they're saying is that most patients show the MECFS reactivation. Sorry, my keyboard fell. But it's not necessary that they all had severe infections. The objective of this study was to investigate antiviral immune response against reactivated ubiquitous herpesvirus and endogenous retrovirus after mild or asymptomatic infection. So I discussed that before. Their cohort, they had 3 cohorts. They used 2015 population. So there was blood donated and there were blood samples from 2015, anonymous samples. They used those to create a baseline for COVID negative patients. The reason is that even if they think somebody is COVID negative nowadays, or in when the COVID started, it was not exactly guaranteed that they will not have COVID because they could be asymptomatic. So to rule out or to confirm that somebody was COVID negative, they tested these individuals in 2020, their plasma reaction compared to 2015 plasma's reaction. So wherever 2015 plasma reacted with IgGs for SARS-CoV-2, they took that as a threshold, and then below that was negative and above that was positive. That's how they made sure that only positive for COVID, even asymptomatic, were in the study. So this became the threshold group. Then they had one group that was MECFS positive, known diagnosed MECFS patients, and then they became COVID positive as well. Some of them, and some of them were negative. So they use them as controls. Then they also had another group of patients, COVID patients, who were known not to be MECFS, but then they became COVID positive as well, and some were not COVID positive. And so they used these 6 groups and compared them with each other. So I have already explained why saliva. Here is the research workers' point of view for why saliva. So one of the main findings of the present study is that the distinct antibody fingerprint of latent virus reactivation found in saliva was not detected in plasma. So if you take the same patient and you look at their blood samples, and they do not have EBV reactivation or herpes reactivation or retrovirus reactivation, you may see that reactivation antibodies showing in saliva. This is evident by the lack of significant difference in group comparisons. So they're talking about the diagrams they're showing, contrary to the strong statistical differences in saliva. Herpesviruses are commonly found in the oral cavity. Therefore, their reactivation and subsequent immune responses are easily traceable in saliva, as demonstrated in our study. The triggering event responsible for viral reactivation may not be robust enough in the case of mild asymptomatic versus SARS-CoV-2. So they're giving all the reasons for why saliva had the results and not the plasma. So they're saying maybe SARS-CoV-2 did not create a reactivation everywhere in the body, but more local within the oropharyngeal area. So the antibodies were also found here in saliva, not in the whole plasma. Or even if it was in the plasma, these were weak or trace amounts. Therefore, the antibody signature following mild asymptomatic infection may be confined locally and hence not detectable in plasma. In contrast to latent virus responses, the response to SARS-CoV-2 in saliva samples correlate with those in plasma. So they said, we were able to confirm that if somebody has SARS-CoV-2, then their saliva and the plasma, they both had antibody levels. But for reactivated viruses, saliva showed more often the reactivation signature compared to the plasma. So once again, for doctors, I keep saying it, you're going to become upset with me. Test saliva for these antibodies, and if you cannot, then at least factor in the viral reactivation in the cases of long COVID. Our results further support the use of saliva samples when investigating anti-SARS-CoV-2 antibodies. Furthermore, we propose that saliva samples are preferable when analyzing antibody responses against latent viruses. Kim in Nature says, I'm never kissing anyone again. Well, because you don't want to offer the latent viruses or you don't want to catch them. Okay, so this is it. So we're done. But one last part, just some diagrams to get us situated. So here, for example, this is their figure 1, if I can remember. Here, if you see, this is the BD 2015 is before the pandemic, blood donors of 2015. Healthy donors are the healthy cohort, which doesn't mean they are healthy from COVID. That simply means they do not have ME/CFS, but they developed COVID. ME is the patients of ME/CFS. So this BD 2015 group was used to develop a cutoff to say where the SARS-CoV-2 negative should be seen. Then here is a study. I'm just going to look at one part of it. So let's look at this one. VCA, so this is for the EBV virus, IgG. And if you see in this one, the very first A diagram, look at ME/CFS. This cohort, ME/CFS, I think these were 95 patients, and their HDs were 110 patients, and blood BD 2015 were 50 patients. So ME/CFS group, if you see, are divided into 3 further groups. Those that showed systemic fingerprint of the reactivating virus, the latent viruses. Then local. Local here is those who had the fingerprint in the saliva as well. And then negative are those who are ME/CFS patients, but they didn't have COVID. They used them for control. Same thing here, healthy donors. These healthy were healthy that they do not have ME/CFS, but some of them were COVID positive. Those who were COVID positive, their reactivation antibodies are in systemic, that is plasma, local, that is saliva, or they were negative as controls. So there are 3 control groups. One was 2015 that provided the threshold. Then neg in ME/CFS is a control group, and neg in HD is a control group. So here, let's see just very quickly, this red lock or local. If you see here, this is a significant change for VCA IgG or EBV IgG. On the other hand, if you look at healthy and look at local, so these are healthy COVID positive, they also have reactivation or activation of EBV, but it's not as intense. So the point is not that ME/CFS get the reactivation and healthy do not, or non-ME/CFS do not. All of them can develop reactivation, but ME/CFS develop with more aggression. So this is the same way for the all other kinds of antibodies here as well. Then they have also gotten a panel for herpes viruses too, and then varicella, CMV, etc. So this is the discussion. I'm going to wrap up. The takeaway once again is first study that shows 3 to 6 months after asymptomatic or mildly symptomatic, even in unvaccinated, this study is all on unvaccinated patients. I would consider vaccinated to have the same problem as well. Vaccine has nothing to do with the EBV itself. So the patients within 3 to 6 months, if tested, show reactivation. ME/CFS patients show more aggressive reactivation, plus EBV and HHV is more aggressive in them. So this is the importance for testing, then have a management protocol. This also helps figure out why some of the post COVID patients are not explained fully by vascular disease or by um, autonomic dysfunction or by GIT dysfunction or by anti autoantibodies. That is maybe because they also have latent virus reactivation. And one more thing that they said that was interesting was, in case of these reactivations, it seems like this reactivation becomes more chronic and more evident. And I have seen, for example, I've seen a patient who, seen meaning I know her, who has gotten EBV reactivation, and that EBV does not cycle back towards the calm state. It just is reactivated and it's there now. So that is the discussion. Thank you very much for your time. Have a happy Thanksgiving. Please like, subscribe, and share. If you would like to support this work, there are links in the description. You can buy me a coffee, or you can use PayPal. You can become a patron. I would love it if for $5 per day, per month, per day would be great too. Per month, you can become a patron, or you can buy Dr. Bean's plan as well. So thank you very much, and I'll see you after the Thanksgiving. I was planning to have Dr. Paul Merrick with me on this Friday, but we'll see. I have to discuss with him tomorrow for the topics. Just a quick question here. Travers Flynn says, is saliva test common at places like Kaiser? I am not sure. That is the problem. That is why I say that if you cannot get it, then assume it that way and manage patients with that. Important thing is blood samples may not show it. So for such doctors who say, hey, your samples are clear, please show them the link to this study. Don't show them my video, they'll become upset, but at least this study's link. Cynthia says, Zoom walk on this Saturday. Yes. And also just a heads up, I'm planning to travel for 10-20 days. I will do the lectures during that, but during the international travel time, it is possible that for 2-3 days going and 2-3 days coming back, I might take a break. So just a heads up, the dates are not firm yet, but possibly end of next week to 22nd December. So let's see. MS says, thanks a lot. Lots of new info to take to my doctor. Yes, absolutely. And please, 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 if you have long COVID, please consider light therapy, near infrared and sauna, both separately. And I've done those discussions separately as well. John says, going home. Yes. So after many decades, my brother, who's a Canadian, he is going to Pakistan, and he said, why don't you come as well? And I said, all right, I would love to come as well. So that's what's happening. Thank you very much, Paul. Jerry says, yes, Dr. Merrick. Yes, absolutely. So I just want to make sure that we have a topic to discuss, and then we can discuss that on Friday. Okay, cool. So thank you very much. Like, subscribe, and share. That is the easiest part. Comment as well. That is even easy. And then if you would like to support it, there are links in the description. Thank you. And I would see you day after tomorrow. Have a great Thanksgiving.